take this opportunity. Thank you. Let me take this opportunity to welcome everyone where you are. Good morning, good evening, good afternoon, where all my colleagues in the diaspora are. We are pleased today to have this opportunity to have a webinar focusing on healthcare, which is an interesting area for most of us in the diaspora. And we're very pleased to thank the State House Diaspora Unit, including Mr. Mohamed Bagonza, for organizing these opportunities for us in diaspora. I will start with thanking my presenters and also welcoming Mr. Bagonza here to maybe share a bit more about the State House Diaspora Unit before we start off. Thank you. Mr. Bagonza, you're welcome.
Yes, Mr. Moden, thank you very much for today. Greetings to all of you, distinguished Ugandan joining us from all over Africa, Europe, North America, Asia, Middle East, Australia, and every corner of the entire world. It is my pleasure to welcome you to this episode 7 of our Uganda Global Diaspora Engagement webinar series. I would also like to start by thanking each one of you for taking time to join us. Your ongoing participation shows your unwavering commitment to Uganda and your desire to actively engage in our country's development, no matter where you reside. We established the Uganda Global Diaspora Engagement webinar series with a simple but important objective: to bridge the information gap between Ugandans living abroad and the government of Uganda. Many Ugandans in the diaspora have repeatedly told us that they want to contribute more to Uganda's development, but often lack timely, reliable, and direct information about government programs, investment opportunities, and the available services. Through this platform, we are bringing government institutions directly to you, enabling meaningful dialogue, providing accurate information, and creating practical pathway for engagement. And of course, you know, we have covered a number of webinar series in different sectors. This evening, we turn our attention to an issue that affects every one of us, regardless of where we live: our health and well-being. Good health is not merely a personal matter, it is the foundation upon which families, communities, business, and nations thrive. As a member of the diaspora, many of you are making tremendous contributions to Uganda through remittances, investments, skills transfer, and international partnership. However, while we often discuss financial investments, we sometimes overlook one of the most important investments of all, which is our health. Today's discussion on the healthcare investment in Uganda, diaspora mental health, and the promotion of the quality healthcare and insurance is therefore both timely and important. We shall explore opportunities within Uganda's healthcare sector, discuss the importance of medical insurance, reflect on the growing importance of mental health among diaspora communities, and examine how all of us can contribute towards strengthening quality healthcare in Uganda. This conversation also aligns with government's broader vision of socio-economic transformation. A healthy population is essential for productivity, innovation, and sustainable national development. As Uganda continues to expand investment opportunities in the health sector, the diaspora has an important role to play, like you will hear from our panelists today, not only as investors, but also as professionals, innovators, researchers, and ambassadors of knowledge. I therefore encourage all participants to actively engage throughout today's session, ask questions, share your experiences, and take advantage of the expertise of our distinguished panels. And this one, we chose them wisely. Allow me to express my sincere appreciation to our speakers for accepting our invitation to share their knowledge and experiences with us this evening. Many of you have been hearing about Dr. Warren Namara. Today, you are going to get from him directly. And our distinguished panelist from Ministry of Health, Mr. Brian. I also wish to thank our moderator, Mr. Moses Mulimira, for accepting to guide this important discussion. Mr. Mulimira, you know him as he achieved a number of awards, and we always we praise him on how he has promoted Uganda in terms of the health sector, having a very big group platform in the United Kingdom. The strength of our nation lies not only in those who live within its borders, but also in the millions of Ugandans across the globe who continue to contribute to its growth and development. Together, let us continue building the 𝐿SA diaspora and the 𝐿SA Uganda. I encourage each one of you to mobilize fellow Ugandans in the diaspora to participate in this webinar series. They provide the unique opportunity to receive timely, accurate, and first-hand information directly from government institutions on programs, policies, and opportunities that affect you. Let us become ambassadors of credible information by encouraging others to join these conversations rather than relying on hearsay, misinformation, guidance, or unverified sources. I thank you very much for God and my country. Thank you, Mr. Moderator.
Thank you, Mr. Bagonza. Just to add on what you have said, I want to thank His Excellency the President for creating this unit and also for his leadership. For myself, I'm aware this unit, the State House Diaspora Unit, has been an effective bridge for us as Ugandans here in the diaspora, and it's given us an opportunity in terms of addressing our concerns, offering our feedback, and we want more of you to offer these opportunities, please, if possible. Just to add on, someone was asking me, who are you, Moses? Yes, I didn't put much of myself out there, but Moses Mulimira, I'm based here in the UK, London. I'm a Ugandan diaspora. My interests are around mental health. I've been involved in psychological therapies here in the UK in terms of the NHS. Currently, I'm working as the global project manager involved in different countries of supporting the workforce. I'm also a research student currently in terms of my doctorate, focusing on public health. And health is an area of advocacy for me, and I've worked closely with the Ministry of Health, especially the Permanent Secretary, Dr. Diana Trine. So that's me. So there's an area of interest, and I'm aware diaspora's interest as well. So I will start with, if you don't mind, I'll start with a friend called Brian Mruswata here, whom we've been recently we met at the World Health Assembly here in Geneva. So I'm pleased to see you, Brian. But also, I see your role as very important for me because you are a lead in terms of the global partnerships, which are an area I'm also interested in terms of partnering with Uganda. So before I allow you to come in and share a bit of yourself, just wanted to give a little bit of credentials to you. Assistant Commissioner for Global and Regional Health Partnerships at the Ministry of Health. And also you have over 17 years in health governance and law and policy, advocate in the High Court of Uganda, former Principal Legal Officer, Ministry of Health, leads Refugee Secretariat, Ministry of Health, and represents Uganda in the global health diplomacy. It's been a pleasure for me to meet you in some of these global diplomatic platforms and seeing your work you're doing, especially around Ebola and other things. Brian, if you don't mind, I can bring you in just to share a bit more about yourself so that the audience may know before we start. Thank you.
Yes, good morning, colleagues, and thanks, Moses, for that introduction. May I start by acknowledging the presence of my co-panelists. Dr. Namara, my boss and our successor from the unit which trained me and mentored me. And of course, Mr. Bagonza, the head of the State House Diaspora Unit. And Moses Mulimira, I appreciate and celebrate the wonderful work which you are doing with the Uganda-UK Health Alliance. I also would like to acknowledge our diaspora, our 𝐔𝐠𝐚 and brethren who representing our flag abroad. We celebrate your efforts, and we know that one of the most celebrated people are you, and yet you are some of the biggest resource we have on the continent, and which actually can advance the cause of Pan-Africanism. Yes, in terms of myself, I think Moses has pretty said much. I have had quite a long-standing public profile. From the time I started my work in the State House Health Monitoring Unit, and I spent there a couple of years, maybe 8 years, until when I joined the Ministry of Health from 2017, where I have been deployed to date. I head the Department of the Division of Global and Regional Health Partners, and my role is simply just to act as a link between partners such as yourselves, our people in diaspora, and the Ministry of Health. And my role is actually to look out for how we can leverage on the power of the diaspora, on the power of our global partners out there to help us achieve health sovereignty. So I guess in terms of introduction, that speaks, pretty says much about myself, of course, other than the fact that I am bred and trained from this country. So I want to thank the State House Diaspora Unit for convening this timely discussion. And of course, the diaspora represents much more than just the remittances we receive as a country, but it's a major source of professional expertise, investment, capital, innovation, international networks, and goodwill. Of course, our responsibility as the government is to connect those resources, clearly define national health priorities through partnerships that are properly structured. So for us as a Ministry of Health, our question is not simply how much support comes into the sector, but whether that support can strengthen our national institutions and improve access to the highest attainable health services and, of course, knowledge transfers and technology. So we view our Ugandan diaspora as an indispensable partner in the socio-economic renaissance. So as an advocate of Pan-Africanism, myself, I would actively engage our Ugandans living abroad to contribute their skills, expertise, and resources towards decolonizing our systems and building a self-reliant country than just simply depending on the donors who come with their vested agendas. And it's our belief that this form of this diaspora shares our deeply interconnected destiny with our continent. So we are happy, personally happy, to be part of this narrative. And yeah, I thank you very much.
Thank you, Brian, for this input. As part of this, Dr. Warren, I'm coming to you after, but I just wanted to, because Brian's time is a bit limited, I wanted just to get a little bit of few questions towards Brian, and then we see how we can negotiate and then come back to you, Dr. Warren. Brian, I have a few questions here as part of our interaction. As the Ministry of Health lead in global and regional partnerships, what is Uganda's current strategy for strengthening international cooperation to improve healthcare and delivery and health outcomes for citizens?
Yes, thank you very much. Our approach is to ensure that international cooperation is country-led and then aligned with our national priorities. Of course, the key reference points are the national, the development plan, the NDP4. We have our strategic plan as the Ministry of Health and the Uganda National Health Compact. So these frameworks really place an emphasis on universal health coverage, stronger primary health care, health security, and building national resilient systems. So in practical terms, we are encouraging our partners to move away from fragmented short-term projects and towards support that strengthen our national systems. So this means that we must align our investments with the government priorities. And therefore, this necessitates agreed coordination and reporting structures that build the capacity of Ugandan institutions And ultimately, it may also necessitate co-financing on the government side, but this would help us to transition and wean off from external funding, because the recent cuts have demonstrated, due to the changes in Washington, have demonstrated that external funding is no longer sustainable. So we are focusing more on a one plan, one budget, one M&E framework, which is a harmonized framework designed to eliminate this sort of fragmented aid and streamline resource allocation, and therefore align with the national systems to maximize impact. So our priority areas for cooperation include, building the health workforce, because we do have a skills gap when it comes to specialized care, and we believe our diaspora can help us to fill this gap. We do have a gap when it comes to essential medicines, vaccines, diagnostics, and medical technologies, including having a digital health ecosystem. So we also need to improve our lab and disease surveillance capacity, and then we need to invest more in our specialized care systems, mental health research, and innovation. So our growing priority is to sort of have health sovereignty through local production and then investment in specialized hospitals. These are the two main priorities for the Ministry of Health: local production of medicines and then specialized hospitals, because these are the two areas where we have identified a lot of resource drain. We spend conservatively about maybe 80 million as government dollars every year. The private sector could maybe reach more than 100 million in medical tourism. And we are net importers of vaccines and medicines, which really, that's why we have flagged this as our investment priorities on the path to achieving health sovereignty. So, but to do this, we cannot do this alone as Ministry of Health. So we leverage on our partnerships, bilateral, multilateral, and of course, our diaspora. We are trying to reach out to our diaspora because we know that this is a very useful asset for us. So we believe that this cooperation will help us improve access and quality of health services. And this is the point at which we say that, yes, we need our diaspora, and we need to build health sovereignty rather than having parallel programs, which is normally the desire of the donors. And we believe if we work together, we can achieve country ownership and achieve our national health plans. Thank you.
Thank you, Brian. I'll do a series of questions, then we'll go around. The other question, which I'm quite passionate as well, obviously Ugandans in diaspora have expressed an interest to invest back home through different ways. I wonder what the Ministry of Health has put in place as a framework to support us to come home.
Yes, the Ministry of Health and the government of Uganda as a whole actively developing structured frameworks to engage the diaspora. And a key initiative is an innovative financing pilot that aims to leverage diaspora remittances with blended finance guarantees to support priority health services. The Cancer Institute is spearheading one of them with our diaspora, and of course together with the Ministry of Finance and the Ministry of Foreign Affairs. And we are trying to create a fiscally secure and scalable model for mobilizing sustainable health financing. So we are also working to establish a coordinated approach with our embassies to support initiatives that can attract investment and engage highly skilled diaspora, Ugandan diaspora in the global community. Of course, as I have said previously, the two investment priorities we have are investment in specialized hospitals and then the local production of medicines. So I will speak now to some of the approaches which we are taking, which we are undertaking. So, and we believe that if we work with the Ministry of Foreign Affairs and the Diaspora Unit and our missions abroad, we could try and attract some of the skills we need. I know that the Ministry of Foreign Affairs is also trying to work on a database of diaspora, of our people who are in the diaspora, while the Uganda Investment Authority, also I'm aware, it provides a one-stop center for investors and a dedicated diaspora desk. So in terms of policy, the national diaspora policy is also being worked on. But of course, we acknowledge our limitations because we do not have a fully integrated framework that covers every form of diaspora participation. However, the direction is clear because we believe that the diaspora would provide for a more predictable channel of investment because they have the country at heart. And we believe that it would foster technology transfer. So within the Ministry of Health, we believe that our diaspora professionals and organizations can engage through formal partnerships with us, including with our national and regional referral hospitals, but also from the arm of research, they could engage with, we have a National Health Research Organization, which has research constituent bodies like the JCRC and the National Chemotherapeutics Institute. We also have the medical councils that they can engage into formal partnerships bilaterally with us and those other affiliated institutions under the Ministry of Health. By way of maybe memoranda of understanding, we could maybe have visiting specialist programs, or we could maybe have hospital university training, telementoring. We could engage in joint research. Maybe we could also work on investment partnerships in those priority areas. Then in this age of AI, we could maybe work on digital innovation. And then, of course, I will submit ad nauseam, including support for local pharmaceutical manufacturing and development of specialized hospitals. So I believe for us, the next important step is to have a dedicated diaspora coordination mechanism. I'm thinking of having a verified registry of professionals and organizations and have a transparent pipeline of priority projects and institutional needs. And of course, we have developed a new law for NDA, which sort of gives a robust regulatory and licensing guidance for those who may need to support with logo manufacturing. And I believe the more engagements as this we will have, it would help us develop these personal contacts, and then we can sort of have these partnerships going forward as we work on the national diaspora policy. I'll give just even one live example in Lubowa Hospital. Because it's going to be a state-of-the-art hospital, and we have identified the skills gap for specialized doctors, and we really, and I will use this opportunity really to reach out to our Ugandans diaspora, because our first priority is to have these people to come and work in this hospital. We hope to have it done within the course of next year. But rather than employ foreigners, we would actually wish to give this slot to Ugandans so that they may come and contribute to the human resource needs of our country. Thank you.
Thank you, Brian. Very comprehensive answers to these questions. And my last question to you, looking ahead, what key areas of collaboration would you like to see strengthened between the Ministry of Health and the Ugandan diaspora communities? If you want us to come back to build some, what are the key areas you want from us?
Yes. I would, of course, there are several high impact opportunities, but the first principle is that the investment should respond to our priorities rather than to create standalone services that cannot be sustained. So Our investment priorities will cover the specialized and emergency care. We, of course, have some infrastructure needs as well because we need to have more reference labs. Right now, we have only the 𝐔𝐠𝐚𝐿, the Central Public Health Laboratory, and yet we know that Uganda, being situated in the tropical belt, is quite prone to infectious disease outbreak. Then workforce development, as we say, I believe that the greatest human resource we have as a country are the people, the Ugandans living abroad. And then we, of course, pharmaceutical manufacturing is really a big gap. So we think that medical technology, because we are in a digital age, also offers us some major opportunities. We need an ecosystem. We need to eliminate paper transactions in our health system. So we would welcome any support that contributes towards building electronic medical records, telemedicine, remote patient monitoring, lab and pharmacy systems. But these technology investments must be interoperable and must come with the component of training, maintenance, but of course, ensuring that there is data protection and privacy. So connected also to the need for local manufacturing is we are thinking of having a dedicated pharmaceutical industrial park to provide international GMP compliant infrastructure. GMP is good manufacturing practice, because we have realized that although our local manufacturers have really attempted to cover the gap of, importation of medicines, but they have been struggling with, being GMP compliant in terms of being accredited by the gold standard, maybe WHO, FDA, gaining those regulatory approval, because just even because of the infrastructure, the way they manage the utilities, the way they manage waste treatment. So we believe that if we had a dedicated pharmaceutical park, and this aligns actually with the vision of His Excellency. He has advocated for a long time that we could have a dedicated pharmaceutical park where we could put all our manufacturers of pharmaceutical products, as opposed to having this normal conventional parks which are already in place, but they do not necessarily serve the purposes of a GMP compliant pharmaceutical plant, which I believe we have actually developed a concept regarding this pharmaceutical park with the Uganda-UK Health Alliance. So of all the 67 local manufacturers we have, only about maybe 2 of them can meet international GMP standards. So we believe if we could invest in a pharmaceutical park, we could actually reduce our reliance on imports, because we spend almost nearly $700 million US dollars in imports in medicines. So this is quite a drain on our resources and gives us a negative balance of trade, because 5% of our total imports, you can imagine, goes towards the purchase of medicines. So if we could at least invest in this park and then attract investment in the local manufacturing of medicines, this would it would help us to achieve health sovereignty. Thank you.
Thank you. Thank you for that input, Brian. Yes, as I move away, I want to ask my audience to ensure I actually keep some questions, Brian. I will move to Dr. Warren if it's okay. Just before I open up the floor for you, Dr. Warren, just a brief about Dr. Warren, currently the director of our State House Monitoring Unit in Uganda. Dr. Warren has experiences in public health, as a public health physician, infectious diseases, and for over 40 years experiences. I want to look at some of your distinguished credentials: 30+ years in health system strengthening and disease surveillance, former director of Uganda National AIDS Control Program, former UNAIDS country director in Tanzania, senior technical roles with UNAIDS, World Bank, World Health Organization. So you've been across everywhere, alongside training in London School of Tropical Medicine, Leicester, and Toronto, across the world. Dr. Warren, I want to open the floor for you just to share a bit about yourself and also welcome some of our guests here today. Thank you. You're on mute. Kindly unmute yourself.
Unmute, correct, correct. Can you hear me now?
Yes.
Yeah, thank you very much for inviting us, and I want to thank all the panelists that are in. I hope the diaspora population beyond this, just few people are also listening so that we share what we think we have. My name is Warren Namara, Dr. Warren Namara, and I'm a physician, a public health physician. As you have seen, I've been around for a bit of time. For the last 40 years, I've been in the field, and pretty much I've been everywhere. I hope I have contributed in very modest ways. And I want to thank Brian for having elaborately given a treatise of what is there on offer for the diaspora. Number one, the diaspora is most welcome to contribute to what we are doing. I've been around. I think diaspora is not, all that glitters is not gold. East-West home is best. And there are opportunities for investment. And I think Brian rightly said a few things. What and who are we as the State House Health Monitoring Unit? I would like to briefly explain what we do. And Brian is part of the group that formed up this unit right from the beginning, together with Dr. Diana, the current permanent Secretary Minister of Health. This is a unit that was set up pretty much as a third eye for the president, if I can paraphrase it that way. The first eye is the president's eye. The second eye is Minister of Health. The third eye, and the very small eye too, is the State House Health Monitoring Unit, to basically look at the delivery of health services, do a number of monitoring and evaluation efforts, look at the needs, look at what we are doing very well and what we are not doing so very well, and make an informed recommendation to the president. That's what, in a nutshell, we do. That's what Brian and his colleagues set up us to do. But we look at it in a number of ways, and I want to go through many of them. But basically, how well is government doing for the population in Uganda for purposes of health? And where are the areas that need to be addressed? And I think the purpose of calling the diaspora to come in is to look at areas that are potentially good for investments. And I'm very glad Brian looked at it. But suffice to say that we know how much money comes in from the diaspora, about $2.5 billion every year. So there's a bit of money that can be invested. And so we thank everybody who's in the diaspora who contributes in many ways to the delivery of health services in the country. You don't have to build a whole Mulago hospital, but if you send money to your relatives to go to Nakasero Hospital, which is an investment from the diaspora, you have contributed greatly to Ugandan health. That's on the micro level. But again, I think we shall dig deep and look at where we can invest in a more subtle and a more detailed investment opportunities, which Brian touched on. If you want me to continue, I'll continue, Mr.
Yes, you can continue, but we have a few questions I can also share later. But
yes,
go on.
yes. So we are an independent body that reports to the president. In many cases, we look at one, these drugs that the government gives to the districts, to the regional referral hospital, do these drugs reach where they are supposed to be? When they reach there, do they get utilized as they should, or they are stolen? Now, in many cases, we find that some reach and some don't, and that's part of our work. And when they have stolen these drugs, which they very often do, we also ask them to talk to the police, because we work very closely with the director of criminal investigations. Why do we do that? We want the money voted by government to do what it is designed to do. Nobody should steal drugs that are meant for Dadali Hospital. And when you steal these drugs, what are we supposed to do with you? We arraign them to the courts of laws. And that's why there's an anti-corruption. That's why there's the director of public prosecution, whom we work with very closely. And these thieves are normally addressed comprehensively there. In most cases, we catch them, they pay back the drugs, they also serve a sentence, they are also stopped from holding public positions for the next 10 years. Brian knows that law very well. What else do? We have human resource. The Ministry of Health trains, recruits, deploys human resources. Do we have enough of them at the periphery, or we don't? And our job is to basically show the president that we don't have enough, or that we have enough. And in most cases, we don't have enough. We make recommendations to the Ministry of Health, which is usually the parent ministry. And we also advocate to ensure that people are recruited and they fill the periphery areas. Remember, Uganda is a decentralized position, so the Ministry of Health works, supervises, evaluates, monitors up to the regional referral hospitals. Beyond that, the Ministry of Local Government superintends that area, and we also give them that information where we think a certain percentage of establishment is not reached. The third area we look at is money. And we are now hard pressed with money. You all know what has happened on the general, the capital inflows into the country, with most of the donors shutting up. I think you all know that the American money is not flowing into the country as well as it should have been. And but whatever we get at the periphery, does it reach where it is supposed to reach? Is it used in the correct manner? Do they account for it? If there is failure of accountability, working with the Auditor General and the Anti-Corruption Department, we ask these people who have failed to account for this money to have a strategic discussion with the police, with the Director of Public Prosecution. And in most cases, we are not wrong. We take no prisoners because we have little money. We think this money should go where it must reach. And I can tell you that we've been able to address this very comprehensively. I think you must have heard about, so the diaspora, when you are thinking of investment, you must be sure, you must be comfortable that the State House Health Monitoring Unit under the President will be able to follow that money very closely for its purpose. The fourth area we look at is equipment. And this is where the diaspora can play an extremely important role. And Brian touched it. We need a lot of specialized equipment. We don't have enough of them. We don't have all the echocardiograms. We don't have all the equipment that we can use to look inside people's tummies and stomach and intestines, endoscopes. We don't have all the x-rays that we need. We don't have all the MRIs that we need. And lastly, some of the high technology like the PETs, we don't have them. This is where the diaspora can really play an important role, because you have the capacity, you have the connections, you also have twinning of the universities and hospitals. You also have other areas that you can exploit for the benefit of Ugandans. We have the data on where we need what. For example, all the teaching hospitals, Mbale Teaching Hospital, Mbarara Teaching Hospital, Gulu Teaching Hospital, Namari Teaching Hospital, Jinja, they don't have all the equipment that we need. And what a difference it would be if the diaspora was able to contribute to that area of support for purposes. The other one, which I think I should not lose sight before I keep on babbling, is we have all these specialists, but we need super specialists, and Brian touched on it. Mm. You people live, and I'm a former student of University of Toronto, U of T, and I know the capacity. I'm a former student of London School of Tropical Medicine and Hygiene. You have the capacity to create twinning and interlocutor with the university teaching hospitals, namely the Gulu National Referral Teaching Hospital, Mbale, which is also servicing Navumari, rather all those universities in the east. Then you have Mbarara Teaching Hospital, which has got to be. You could do very well by connecting some of those universities that you either belong to or work with or know or have inroads to be able to create capacities for capacity building, training for super specialists, and above all, transfer of technology, which we don't have. And I think Brian talked about it, the transfer of technology, which is very, very important. I could go on and on, and yes. The State House Health Monitoring Unit has all these data. We can put it to anybody. We can support anybody. We can also advocate for any support that we need. But believe you me, we know what we need, and we also know that you are capable of contributing in no mean way to the efforts that we need.
Thank you.
Opportunities for the diaspora, private hospitals and clinics. Remember, you have tax rebates, you have tax exemptions, you have land access. I think the president keeps giving land to people who want to develop. You must seize these opportunities. For example, an interest rate in the Ugandan commercial bank is far less than any other bank outside here. It is rather is more. Your banks, where you sit, either in London or in Alberta or anywhere in America or anywhere in Australia, the interest rate is far, far less than what you'll get here. But then at the same time, the government will give you almost all the rebate that you need. Tax rebates, importing of equipment that is free of charge, tax exemption if you are going to repatriate your money. And you can, of course, come, invest, take back your money if you so wish.
Thank you.
Opportunities exist. Remember, we know what we are as a country. We need investment. We have to attract investment. We have to protect investment. So the diaspora, it is all up to you. You have everything on offer for yourselves, quite very frankly.
Thank you.
Yeah.
Yeah, thank you, Doctor. Very interesting. I have a few questions here, which I was interested in getting your thoughts.
Sure.
One is around the, the unit is very, we've seen how the unit works. Very, very interesting and very good outcomes as well, in terms of creating transparency, in terms of creating leverage, in terms of improving healthcare. However, we wanted to know if how much you're using the digital technology and yeah, to support you in your work.
You see, we use a lot of digital technology, but let me tell you what is most interesting. Technological transfer is not easy. But we have the digital monitoring of, for example, electronic health management system at the hospital. We have that. Then we have the national data platform where we know who was born today, who died yesterday, and what is the disease distribution. All these forms very, very important background information for purposes of planning. For example, because of the EFIA or because of the electronic health management, we are able to control the epidemics that have actually hit this country. Because we get real-time information. If there is an outbreak in one form or another, it is immediately put into the system and investigations begin. And we immediately establish the trend, the foci of the information, of the epidemic and the control measures. So I can also tell you that it is not 100% acceptable yet. But where is our eye? Our eyes are that we must have an impeccable digital transformation system where I'll be able to sit in my office and know how much time a patient has spent in so and so's clinic, what drugs she has got or has got, what is the balance of the drugs in the pharmacy, where is the need now, which drug is necessary. That is the strategic vision and direction in which we are working towards. And the Ministry of Health is actually doing very well on this. We have all sorts of platforms. We got a professor from University of Loughborough in the UK who has been developing a very good system for that. We have our own other EFIA. We have our own other digital transformation from WHO. So we are very, very, very conscious about a digital transformation.
Thank you, Doctor. Very, very good area, which will also help in monitoring. The other one,
and then, of course, the diaspora. This is where you have a lot of. This is where you have a lot of capacity more than here. Quite very frankly, this is. I mean, you have all these applications. You are exposed to some of these high-tech countries. You could transfer all that technology to us.
I agree. The role of the diaspora in this is key as well. Thank you, Doctor. Yes. Thank you. Very, very good. The other question I wanted to see, we see a lot of, from the diaspora, our colleagues on the ground, the health workers, being monitored, being saying issues, for example, what we saw with Minister visiting in Mbarara, the video which was circulating around. Although those are great ways of monitoring and improving health services, I wonder whether there's other ways you see in terms of improving accountability and transparency and supporting and motivating our health workforce from your side.
Oh yes, you know, I'm very glad that the ministers are no longer sitting in their offices, but they are also moving to the field, which I think is very good. But I also want to assure you that a lightning visit is not likely to yield sufficient result. And they know it because they are professional, and we also know it. For instance, if you mention the case of Mbarara, where Dr. Honorable Dr. Bariumunsi came and visited, he visited, and that was very good. But as a unit, we had spent there 6.5 weeks. And what were we doing? We were looking at everything they do, 𝐃𝐢𝐚 supervision, monitoring and evaluation and supervision. That's one area that we have to do. Don't go in to find fault. Go in to find a way of supporting them, and we do that, including training, identifying their weak areas and asking or training them or advising them how to improve, Areas that they are not doing very well, and telling them or asking them to be able to do what they should do. And at the end of all these visits, we have what is called an aid memoir. We agree. We have found that you were absent 34% of the time. Why were you absent? Because you had worked for so many hours without relief. What is the solution? Train more people, recruit more people. Who does this? The director of the hospital. When does he do it? He does it in September 2026. How much will it cost? It will cost so much. Who pays that money? Ministry of Health. So our purpose is to make sure that we train and basically move the workers from the area of basically giving up to an area where they can make a change. And then we support them by giving them more people, because one of the biggest problems we have seen and rarely identified is that we don't have enough manpower. Mbarara Hospital, which you talked about, we found that out of 100 staff members they needed, they only had 26, call it 26% of staff. How do you expect that 26% to offer service? So, number one, we advocate. We supervise, train, identify problems, try and address problems, and then advocate for more staff and more recruitment. The other thing that we make sure that we do is I'm also a student of management, besides being a physician and epidemiologist. Management at the local level is really not small. Think of a duty roster for people. You find a place doesn't have a duty roster. How do you account for your time, Dr. Namara? How do you account for your time? Where's your duty? How many days are you supposed to work? Why didn't you do it? So those simple managerial things are also taught to them. The other thing we do is continuing medical education. Medicine changes every day. Medicine changes. So we ensure, we also encourage the doctors, the nurses, the pharmacists to participate in continuing medical education. Because that's an indelible reference in medicine. You have to keep reading. If you don't read, you can't continue to do the work. We also encourage them to do that. And then we can hold them accountable.
Thank you, Doctor. Doctor, before I go to the audience, I'm aware there's an interest of questioning coming up.
Sure,
I just wanted to ask your vision for the next 5 years, given you have a bigger vision around the country of healthcare. What do you want to see, and where do you see us as Diaspora coming in? That's my last question before we
Let me tell you, the vision is very clear. There is no doubt about where we want to go. There is, you've heard of most Ugandans running abroad. And they go and line up at the national, whatever you call it, National Health Services, in NHS in the UK. We don't want them to go to India. We don't want them to go to Turkey. We don't want them to suffer. A healthy population serviced by a competent population or medical staff. That's where I think we need to go. It is difficult, but it is doable. A professional medical cadre, from consultants to nurses, they ought to know what they are doing. We don't want to be left behind by technology. You hear of PET, people are looking for PET, people are looking for, it's nothing else other than just advanced technology for diagnosis. We want to make sure that we have that. But we also want to make sure that there is transformation, a complete ideological transformation of individuals, where medicine is a calling, not a, very few doctors die rich. We never die rich. You just die with one stupid Benz and maybe a house, and that's about all. But we are not looking for doctors who are going to have skyscrapers. We are not looking for doctors who are going to have a whole world of buildings in Kampala. That's why we are called doctors. It's a noble profession. So we look at that as a calling, and we hope that we can get a whole section of society, and it is there, who can think like that.
Thank you, Doctor. Very interesting. I'll open up I don't know, my colleague Tofa is here just to look at the questions from the audience.
Mm-hmm.
Tofa, are you okay to help me with any questions?
Hello?
Yes. Help me with any particular questions from the audience, if you can read any. Or
Tofa, do you want me to take that on? Because there's a lot of
Yes.
questions in the Q&A.
yes, go ahead.
Please go ahead.
Okay, so thank you very much for this conversation. First of all, my name is 𝐔𝐠𝐚𝐽 Mbabazi, and I am based in Edmonton, Alberta. So I'll just go through the questions in the Q&A. The first question is from a gentleman called Tash. What mechanisms does the Ministry of Health have or intended to establish to ensure that Ugandans in the diaspora investors are highly skilled professionals who return home to contribute to the country's healthcare sector, receive the institutional support and coordinated government action necessary to turn their investments into sustainable national assets? And then again, Tash asks another question. There's an apt example of a professional doctor, Dr. Charles Lugero, who has returned home not with just an expertise, but with resources to set up a hospital, a Roma hospital. For 3 years, he has not been able to fully function because of various bottlenecks, and not even a presidential directive was sufficient to get him to support that he needed for his hospital to operate. Then the other question again, from again the same gentleman, medical equipment and investment is extremely costly. What are some of the mechanisms that the State House desk has in place to protect, support, foster investment done by these diaspora Ugandans? So I guess we'll start off with those, and then I can continue with the other ones that are in the chat. Please go ahead.
Okay, I don't know whether Brian, I think Brian, if he's there, he might have to take some, but I can take some if I can. Let me just start with the medical equipment to protect. And number one, everybody in this country, whether Minister of Health or State House, understands fully well the costly equipment of health. We do understand, we know, we've seen them, we've used them, and we know the value. That is why there is a definite, I think they are tax rebatable, and Brian can bear me on this. They are tax rebatable, or there is a tax regime that is allowed. If you want to invest in health, if you want, even if it is not there, it can be created. Let me just put it that way. Now, in the case of Dr. Lugero, I have no idea about this person, but maybe Brian might answer this question. But let me also say this. Investment has got challenges. In any investment, it has got challenges. And sometimes it depends on how one is handling themselves. It also depends on what it is that you really, really want to do. I mean, if you want to invest in health and you're importing televisions or importing, let's say, a vehicle that is nowhere near an ordinary vehicle or nowhere near an ambulance, how do you expect the taxman in Uganda to respond to that? So what I'm saying is that if one wants to invest, there is an investment climate that is very clear. The Uganda Investment Department is here. It is headed by a lady who understands very well. It has got a whole minister who was in charge of investment. I don't think that if you want to invest in health, it can be very difficult. If it is difficult, there are ways of addressing this. The Permanent Secretary Minister of Health can help. In my small ways, I can try to find out and advocate where somebody has got a problem. I see Brian. Brian is still there. Brian, you should take over a few things.
Yes, I believe my senior colleague has actually answered some of the queries, but I will just try to expound because regarding the question that how can, if I remember it well, what mechanisms does the Ministry of Health have to intend to establish to ensure that the Ugandan diaspora investors and highly skilled professionals who return home can contribute to the country's health care sector and receive institutional support? Yes, of course, that's a great question from Tash. The Ministry of Health has already recognized that diaspora investors and highly skilled professions need more than just goodwill. They need structured institutional support and a coordinated government action to ensure that their contributions become sustainable national assets. So these are some of the existing mechanisms we have in place. Of course, there are government-wide entry points because this is not just an issue of Ministry of Health, but sometimes it requires a government-wide approach. And these are some of the entry points. Because the diaspora engagement is facilitated through the Ministry of Foreign Affairs, they have a diaspora desk. Then there is also another avenue afforded by the State House Diaspora Unit, which I believe is very supportive, and the Health Monitoring Unit, as my senior colleague has offered to help, and I know he's very helpful to supporting investment in the health sector. So also our missions abroad, because they have been tasked to engage in economic diplomacy. And I know that this is also another entry point in case you need support. Then we have also the Ugandan Investment Authority. So these channels, I believe they help to facilitate investment, skills transfers, and professional engagement for any investor who wants to enter the market, including our cherished diaspora. So the other mechanism which we have is through formal partnerships, because we are open to engaging through MOUs, through joint ventures, through sometimes we issue off-take purchase agreements for investors who may want to engage in local manufacturing. Then also our affiliated entities, the hospitals and the research organizations also, you can engage them bilaterally because there are various opportunities in twinning, in telementoring, in joint research, in specialist training, and establishing all these partnerships with this institution. Then the Uganda Investment Authority also has a one-stop center for investors. And I believe this also helps to streamline regulatory approvals and facilitate investment. So, and we also have some mechanisms which are under development. Like, as I said previously, we are working on a dedicated health diaspora coordinated mechanism that will include a verified registry of diaspora professionals and organizations, and to create a transparent pipeline for priority projects and institutional needs, and also to guide our diaspora with a clear regulatory and licensing guidance for those who want to return and invest. So, of course, this also goes along with the National Diaspora Policy, which is being finalized, which is intended to provide a predictable channel for investment and technology transfer. And then we have our digital health and telemedicine platforms that will allow our diaspora specialists to contribute remotely while ensuring compliance with the licensing ethics and data protection. So how can this mechanism, the question would be, how can they support sustainability? Because this will ensure that the diaspora contributions are linked directly to our service delivery points, the hospitals, the training institutions, the regulators, and the national programs, rather than just having ad hoc arrangements. And of course, these mechanisms which we have in place also help us to offer clarity on licensing, credentialing, and ethical approvals. Of course, there are things which we cannot just simply waive, especially issues to do with the licensing and standards. Some of these processes are created for a process just to ensure quality control. But yes, easier said than done, but help us to give the direction. As the Ministry of Health, we actually have an entire department which is dedicated to health sector partnerships. I happen to be part of the department, so we are available. We have all these pathways which maybe we have not disseminated these entry points and pathways to our people in diaspora. But I believe the engagement such as this gives us the opportunity to fully disseminate this information because it is very useful. But the institutions are there, and the government of Uganda has taken these very essential and effective steps to ensure that we can get we can offer institutional support for diaspora investments. Now, the case of Dr. Charles Lugero and Aroma Hospital is a new one for me, but thanks for raising it, because it says it is said that he suffers from some systematic bottlenecks as a diaspora who returned home with both expertise and capital. And despite a presidential directive, he has struggled to fully operate for 3 years. I'm not aware of that directive, and interestingly, even my senior colleague, Dr. Namara, is not aware, who is much closer to the first office. But the issue is we are available. It is not too late for him. Mm-hmm. Of course, the regulatory requirements, we cannot circumvent them. But if there are any regulatory bottlenecks in his path, we are there to help him.
Mr. Luswata,
yes?
My sincere apologies in actually interrupting in this conversation. I can give some clarity to Tash is talking about, because I'm also closely, I've been monitoring this case of Dr. Luswata. First of all, I'll give you some context real quick. Dr. Luswata lived in Ontario, Canada. He's a cardiologist, and he went to McMaster University and has practiced largely in Canada. We were part of the group that actually encouraged him to move to Uganda and establish this, because we're trying to set up a group of Ugandan professionals in Canada to actually, especially medical professionals, to come back home, because as Rotarians, Ugandan Rotarians here, we noticed that when we're working through projects, there's a high lack of actually medical people. So we try and consult as we're trying to raise funds for different projects in the different hospitals as Rotarians. And that is, Tash is actually a Rotarian, a Ugandan Rotarian that's on the call right now. So with Dr. Rugero's case, it's very clear that he moved to Uganda 3 years ago. He set up a hospital in Mulago, and he's a cardiologist, and he has equipment that is stuck in a warehouse. And the biggest challenge is that there's this pharmacy that's in a road reserve that's right in front of him. He has a presidential directive. The pharmacy that's in the road reserve does not even have a title. The title was revoked. It's very, very clear. The gentleman is able to move forward with his clinic. He has debt that he's incurring for 3 years. He has door knocked everywhere. So the question is, we have a live example of what you're asking us to bring to Uganda. And this gentleman is struggling. And it actually shocks me that you've not heard of this story, because it's been everywhere. And actually, fortunately, actually on the call right now as well. And we are people that have been in the diaspora in Canada pushing for this gentleman to come. The embassy is aware. The president's office is aware, because there's actually directives about this. And our biggest question is, what's being done. What can we do now that we're on this call? Now you're aware. How can you support Dr. Lugero? That is actually the question here, because we as diaspora Ugandans, and I'll speak for myself as somebody that's in Rotary, there's a lot of need in healthcare in Uganda, a lot of it. The cancer run, the Mulago Children Cancer Unit, like we're trying so hard, but we keep finding these challenges. And we try to get these doctors that are here. Dr. Mukwende said the other day, we have so many professional Ugandans in South Africa. Half of them actually moved to Canada. The best cardiologists here, the best surgeons. I had surgery when I had my daughter. The doctor who was the head of the unit was a Ugandan. And I had a conversation with him and I asked him, why can't you come home and offer us the services? And he clearly states that it's a challenge. When you go to Uganda, it's a problem. And they want to do this. But how do we help them? Some of them are on this call. How do we help them move forward? Thank you very much. I hope I've clarified the questions for the people that are in the chat. And if I'm missing anything, kindly let me know or share in the chat. Thank you, gentlemen.
Yes, thank you. As you were presenting that case, and thanks for the clarification. One of my colleagues who is on the call sent me some information and told me that that issue is a legal issue. I think there is a contestation over the land. So it is not entirely a regulatory bottleneck issue, but I understand that Dr. Lugero is in court with another person who is claiming ownership of the land. And you know, until we finish, until the court matters are decided, I think we cannot necessarily influence or try to even comment on ongoing legal issues. But we appreciate the goodwill and we can only wait. This is the advice I'm getting in my inbox. And I hope that is the case. But if not, we are available to sort of get more details and to see how we can support to the best, to the extent of our ability. But the limitation would still be if the matter is in court or if there is an ongoing legal process. We are mindful of the issues of the separation of powers and cannot interfere with an ongoing process. So I will not comment so much about that case because of the additional information I've received. And I hope this sort of answers generally some of the queries that have been raised on the call. Of course, I will submit ad nauseum that there is a facilitation desk, not only in Ministry of Foreign Affairs, but also in the Ministry of Health. We have an entire department that whose mandate is to help facilitate investment in the health sector. Then we have always tried to, of course, we are bound by the principle of collective responsibility and we adhere to the presidential directives as they come. And this is quite an interesting one. I think I need to study it further. But I would like to just give comfort that we actually encourage public-private partnership models. And we don't want to leave the diaspora investors. We don't want to leave them out, but we are willing to work together. So the goodwill is there, and please use the institutional pathways are in place, not only with Ministry of Health, but other actors, the Health Monitoring Unit, State House, Diaspora Unit, Uganda Investment Authority, the Ministry of Foreign Affairs, and we really appeal to you to use this institutional aspect because they are there to support you. Yeah. Thank you very much.
Yes,
But,
thank you.
but can I also add on to what Mbabazi is? I agree with everything Brian has said. And I know the principle of sub judice, as Brian is talking about. But in order to rest the diaspora feelings and what have you, I would like to encourage Dr. Rugero to come and talk to us so that we understand if it is a case in court, there is nothing we can do, as Brian has said, and Brian is a lawyer, I'm not a lawyer. But if there is an area, if there is a window, if there is something that we can do, we are willing to do it. Because we believe in the law, but at the same time, we believe in supporting the investment. Thank you. He can always approach Dr. Bagonza. He can always approach me. He can always approach Brian. And we shall advise them correctly.
And thank you, gentlemen. I think just really quickly circle back to the situation, and I do believe he's on the call, and I think that we will definitely reach out to him, and I think we should encourage him and support him as people that are working as a diaspora group, because I think that this story, yes, there's some legal aspects of it, but I also think that as an office, he should be given an audience to come in and speak to you, because clearly the world is watching. And like I've said, I'm a Rotarian, and I'll be very honest with you that there's a lot of pushback in working with Ministry of Health and the Rotary because of all these issues. Because when they hear these stories, the stories change every day. It's like the Chinese whisper, right? And I think that if we sit down and have a collaboration with him, it's going to help us. So definitely we'll see how we can reach out to him and have him meet with you and your office and to try and streamline this process. Thank you very much.
Okay.
Maybe, Mr. Moderator, before we leave this issue, I would like to make some clarification. This issue came to our attention, and we managed to find out what is the problem. And majorly the problem is not about the investment and Ministry of Health. The problem was between the 𝐾𝐧𝐠𝐚 and the two developers. But 𝐾𝐧𝐠𝐚 was in the process of removing that structure. Then the other fellow went to court. But 𝐾𝐽𝐶 is engaging court to see how they can resolve the matter. So I know very soon I've been engaging the 𝐸𝐷-𝐾𝐽𝐶. They are trying to sort out that matter, and it will be sorted out very soon. But what maybe the advice we can take from our two doctors who are our panelists today is before we invest, let's get to all the systems, people in charge, get a lot of information before you go somewhere to put up a structure so that you get better advice and they can advise you the good person on how to invest. That is the best way we can do it. The good thing, there are very many offices now where we can run and our challenges and advice can be sought or given. Thank you.
Thank you for this. I think there's someone who has put a hand up for some time, Dr. Manoj. Is it okay to bring him in? Go on.
Yeah, we are bringing him in. Am I audible?
Yes, you're in, Dr. Manoj.
Thank you very much. Fascinating discussion. Just to pick up on a few points, I'll give my brief introduction. I'm a third-generation Ugandan living in UK. I have got 7 medical practitioners in my family, and my son is a consultant general surgeon at Addenbrooke's Hospital. He's an Oxford graduate, and I'm also president of Uganda Europe UK Association, a diaspora organization, and also a past district governor for Rotary International. So I've got some credentials to back me up for what I'm going to say. And in the last 15 months, I've been to Uganda 5 times after 54 years. And I've led 5 delegations in agriculture, tourism, mining and manufacture, and science and technology, including health, education, and infrastructure. What I have found is there's a lot of activity going on about collaboration, but it is disjointed and it is uncoordinated, and the communication is completely lacking. So my challenge and question is, how do you cut this bureaucratic nightmare? And we heard about our colleague from Canada who is suffering, although it's legal matter, but it should not stifle. It should not grind the person to a halt, because the system, if it's that bureaucratic and inefficient, we are not going to get the tenfold growth. So my challenge to you again, I repeat, is how are you going to streamline your one-stop shop? Because looking about diaspora, we got the State House, we got Ministry of Foreign Affairs, and we got the Prime Minister's office. And I'm struggling. The biggest digital infrastructure development company in NHS is based here in Leeds, and I've got direct contacts with them, but I cannot get anywhere. Anyway, I'll stop now, because I want the doctors to and officers to respond to this nightmare that we are going through. Thank you.
Let's take more questions.
Yes, I agree. Any more questions? Anyone's hand up?
Just a second. I'll just go through the. Let me go through the next questions. 1 second. Sorry.
Please go.
There's a question here. Sorry, 1 second here. There's it's not really a question, it's a comment in the chat about. So Uganda offers top IVF and fertility preservation treatments at a fraction found in Western countries. How is the government leveraging these successes to have traction known and scaled up for health tourism? That's the other question. The other question here is Mr. Batusabalaba's story about illness of his mother showed that what we need in Uganda is a robust health insurance scheme, so that when companies invest in the expensive equipment and their maintenance and operation, what is being done to lead us to such an insurance scheme? That's the other question. And another comment: we're trying to ensure, together with a diaspora state house led by an amazing team, to create systems. This is somebody who's commenting on that. And then that was in the chat. Let me just go quickly in the Q&A. Okay, Tashi's question was answered. Sorry, one question here. There's another question here. What does the quality healthcare mean to the patients in Uganda versus the diaspora? Are the expectations different? Beyond hospitals, what does the community well-being look like? Clean water, nutrition, mental health, and safe motherhood. That's the other question. Thank you.
Okay. I'll have a go at Sam, and Brian will follow up. The gentleman from Leeds, the third generation Ugandan or Indian Ugandan, thank you very much for raising the issue of bureaucracy. Since you are of Asian extraction, you know what is called red tape. Red tape was a red tape indeed around files that would go all the ladder in the Indian system and the British system for purposes of a decision making. That's why it derived the acronym red tape. Bureaucracies are necessary devils. They also are important in management of society. There is a government. It has got many structures, as Brian talked about. It's a systems approach. But once a decision has been reached by touching every point in the system, that decision is indelible. The biggest problem is when people come from wherever they have come, and I will say it very loudly, and expect to short circuit some of those areas. Because some of them, and we've met them, they come and say, no, I'm an investor, I'm from UK, I'm from London, I'm from China, I want this done A, B, C, D. Sometimes that's not good. That's what is called bureaucracy. It's a necessary devil in any system, and yet it is indispensable. Britain has some of the worst bureaucracies. To go through the NHS system and get surgery, and you said you are a surgeon, it takes a bit of time. That's bureaucracy for you. But it's a necessary devil. Now, in the case of Uganda, this is what we've tried to address. We have the diaspora unit, supposed to short circuit some of those bureaucratic but necessary devils. We have the Uganda Investment Authority, a one-stop shop center. You go in, you want to put up a factory until you get everything there. And that's what we've done for health. You go to Ministry of Health, it will give you all that is necessary. It will ask you to go to the Uganda Investment Authority to get 1, 2, 3, 4, 5. It's still bureaucracy. It takes a bit of time, but it's a necessary devil, and we have to live with it. But we try to shorten it in the case of Uganda. Insurance scheme, expensive equipment. Brian will talk about it because I think there's a lot of work being done on health insurance. Now, the quality of care. I think somebody raised that issue, and I think it's very, very important. Now, remember, the per capita income of this country versus the per capita income, for example, of Canada. How much money is available per person per year or per time T? We are struggling. We are a developing economy. We can't do as well as, for example, what can be done in the state of Alberta or in Winnipeg. However, there are clear lines and clear recommendations and clear administrative structures to address one. This country has got the highest immunization rate. The strategic vision is prevention, prevention, prevention. We have got some of the highest immunization rate. To talk about measles in this country is very rare. And if there is one measles case in this country, the Minister of Health dispatches all the epidemiologists to investigate that. We've been talking about nutrition because we know, and you have heard the President talk about preventing diseases through nutrition. A lot of work is being done in that direction. Sanitation of the community. Why? We are trying to prevent disease, and once it filters through, it goes the next level of management. Now, the quality may not be similar, may not be even near the Canadian quality, or perhaps, I don't know whether Britain has got to that great of a quality, but that's the direction, that's the strategic vision of the Ministry of Health and the Uganda government. Proper nutrition, the issue of immunization, that one is completely addressed. And then referral. You know, the government phased out the lowest aid post, health center 1 and 2. And we are trying to make sure that we've got doctors even up the health center 3. Right now, we've got doctors at health center 4. Before you reach even the district hospital, before you reach the national referral hospital or the regional referral. All that is to make sure that the quality of care is accessed at the nearest household level, so that a health center 2 will get a doctor in the next foreseeable future. Health center 3, I'm sure, is about to get a doctor. The health center 4, which is usually within the radius of about 25 kilometers, 20 to 50 kilometers, has got more than one doctor. In fact, usually there are 4 doctors. And I think the Minister of Health and the Minister of Local Government is working very hard to make sure that at that level, we are able to have doctors who are even specialists. I can tell you that some of the health center 4s have got specialists, obstetricians and gynecologists. Some of them have got general surgeons. That's where the direction is going. And I'm very positive. Somebody asked me about the outlook of the future. I have a feeling that at Health Center 3, we shall have a qualified surgeon, a qualified obstetrician in the next 5-10 years. I think I leave the insurance scheme to my friend, and of course he can add. Oh, somebody raised the issue of artificial IVFs, and I can't remember the question is. The question was, how can we support that for purposes of tourism? Because IVFs and all those fertility clinics are very expensive abroad. Yes, there's a government effort on this. There is Dr. Sar, who was my very senior in the medical school, is doing a lot of work. And to the best of my recollection, government is supporting him. Why is he supporting him? He's filling a gap, and he's doing very well. He's doing very well. We already get patients from the region for that treatment. And I think Brian might add on, the direction in which we are moving is that we support it to be able to serve as a regional center of excellence. Together with other centers of excellence, by the way, that we have. We've not talked about the Uganda Virus Research Institute, which is celebrating 90 years today. And that's a reference laboratory center for viruses in Africa, actually WHO reference center. If you get a virus in this country, anywhere in the world, we are able to determine what it is. The Cancer Institute in Malawi is being equipped, and it will become the center of excellence for East Africa. We are developing another center for cancer treatment in Mbarara Regional Referral Hospital as a teaching research institution. We've already developed another cancer institute in Mbale, and we launched another one in Gulu. Why are we getting to decongest the center, be able to offer services closer to the population, quality service? Over to you.
Yes, thank you, Dr. Namara. Of course, there is a sense in which we judge ourselves so harshly as Ugandans. And I believe my senior colleague has mentioned it very well, because despite these bureaucratic bottlenecks which we are trying to close, we have also to acknowledge that we have made some tremendous strides. We have over 67 manufacturers, local manufacturers in the country. And because of that, we have been able to sort of provide for at least 60% of the essential medicines in the country. Our challenge remains with the specialized or the advanced formulations, or maybe these NCDs, cancer, anti-cancers. That's where our problem is, and this is where we need support. And of course, even with other service delivery areas, the government has really made a substantial investment in infrastructure. Cancer Institute is a regional center of excellence. UVRI, we do have the Heart Institute, the massive investment there. We see Entebbe Pediatrics. So, yes. Of course, there is no freedom outside the rules, because the biggest mistake that some of our investors make is to try and to circumvent the system. I always advise my clients that please try to follow the system. Just go bottom up, because from the bottom we can actually try and refine the idea very well, so that the project can move seamlessly, despite even all these the procedural requirements you have to go through. And in many cases, issues that deal with health, you cannot compromise even as a regulator. If NDA says this is the standard, you must go through a clinical trial. If the medical council says you must be licensed, there is no way even at the highest level of government that we can interfere with the regulatory standards. So I think for me that is one of the pieces of advice I can give to our friends. But whenever you have a problem, please feel free to reach us, because these institutions are created to serve you. So now I will talk about the issue of medical insurance. The honest answer is that Uganda does not have an operational national health insurance scheme. that provides seamless coverage for citizens both in Uganda and abroad. But the Uganda government is working on a national health insurance scheme, and the bill is under consideration. So we are currently finalizing the bill. Of course, several questions were raised by Cabinet, and we are answering them and completing them, and of course working on some of the essential steps like getting a certificate of financial implications. And we continue to have strategic engagements with Cabinet and Parliament. It is one of our legislative priorities for this financial year for the Ministry of Health, and I hope to get the certificate of financial implication by September so that we can usher it through the legislative channels. Of course, we agree with you that this reform is important because we suffer from catastrophic out-of-pocket expenditures. So creating this sort of risk pooling and more predictable, it will create for us even more predictable domestic financing. So the scheme is still undergoing design, and we hope that we shall have the scheme in place. But in the meantime, health insurance is already available through private insurers and health membership organizations, which are regulated by the Insurance Regulatory Authority of Uganda. Of course, our people abroad also can have their own scheme. I have seen one which is quite innovative that our diaspora is trying to develop for the Ugandan Cancer Institute that can help to serve our people in diaspora and their families. But also, we do have community-based health insurance schemes, like one we have in 𝐔𝐠𝐚𝐧𝐝. The faith-based organizations actually, for a long time, have been implementing community health insurance schemes. So what we have decided to do is, as a ministry, is to strengthen these community health insurance schemes as a pathway for informal and rural communities. But yes, we acknowledge it's not yet a universal program. So, but there is still an opportunity for diaspora responsive products that will allow Ugandans abroad to purchase cover for their parents and dependents in Uganda, and also for them to enroll and pay digitally as we work on the bigger insurance scheme. Of course, this is not something we can rush because we have learned lessons from comparable jurisdictions. In Africa, we have looked at Rwanda, we have looked at Kenya, we have looked at Ghana. They are also struggling. So this is something, because we have such a big informal sector in Uganda. So the question is always, how do you enforce mandatory premiums from these people? So this we are doing actuarial studies and to try and see how best can we make sure that everyone is covered under the scheme. Easier said than done, but it must be done, and we are really advancing this reform on national health insurance. Regarding in vitro fertilization, of course, I just want to briefly expound on what my senior colleague has said, because Uganda is steadily expanding access to in vitro fertilization, with some private hospitals like Victoria, like Dr. Sally has mentioned, leading the way. Of course, there are various challenges that remain with affordability, awareness, and stigma. But government we have part of our legislative agenda this year is that we are working on a human fertility bill. And the objective of that bill would be to develop a legal framework for human fertility services and assisted reproductive technology in Uganda, because this is an area that has also been abused a lot, surrogacies and even IVF. There are some ethical issues. There's been a lot of professional misconduct, and that's why we have come up with this bill. So we believe it will regulate and guide the performance of human fertility and assisted reproductive technology, not only in the private, but also in the private sector. So this is a work in progress, and we hope that we shall have this framework in the foreseeable future. I don't know, moderator, what else I have left out.
No, I think you've been very comprehensive.
Yes, thank you very much.
Sorry, I'll jump in real quick again. My sincere apologies, and thank you so much for answering that question. I'll just really circle back on a quick comment that Dr. Minaj has sent here. He says access to decision makers that are being guarded by gatekeepers. So he is asking that let us have full contact details of everyone and let them respond in a timely manner. That's his comment. That's from Dr. Minaj. Then there's one that has come in, actually, a call that I actually just got. And I'll just go through the statement here. It says, many Ugandans feel frustrated with the quality of specialist healthcare. Patients often spend months or even years consulting with different specialists, paying repeated consultation fees, laboratory work, medication costs that can track up to 2 million shillings per visit, receiving inaccurate diagnoses. By the time they seek care from other hospitals such as Aga Khan or India, they are sometimes told that they are at advanced stages of diseases and at stage 4 of cancer. What options, and they have limited options, and there's no clear indication of what the underlying diseases were when they were getting tested in Uganda. It is important to note that this concern has raised many patients in Uganda questions regarding the specialists in Uganda and the skills that they have and that they offer. The question here invites us, the question for us here is, what are the primary factors contributing to the delayed or misdiagnoses in Uganda? Is the challenge largely attributed to shortages of diagnostic equipment, specialist capacity, referral systems, or medical education? Has this become another money-making scheme from medical professions? What mechanisms exist for accountability and quality assurance amongst the specialists, doctors? How is the Ministry of Health strengthening these diagnostic capabilities, and particularly oncology, cardiology, and other specialized fields? Are there any plans to establish a normal benchmarking process for these diagnoses and these referral timelines and patient outcomes? It's very clear that by the time a patient is flown abroad, they are at the point of dying, and there's no chance of actually saving their lives. What role can the Ugandan diaspora, particularly healthcare professionals abroad, play in supporting and transferring knowledge and mentorship to strengthen specialist services in Uganda? The ultimate goal here is not to criticize the healthcare professionals, many of whom perform admirably well in difficult circumstances. However, it's to understand where the issues, where the concerns are, so we can have a proper healthcare system running in our country. It's very sad that people have to spend millions of shillings and dollars to save a family member's life, yet a simple diagnosis at the beginning would have made a huge change in a person's life. That's the question I have. I could repeat the questions again as we go. I'm not sure how you'd like us to handle this. Thank you.
Okay. I think your question is really about inaccurate diagnosis, delayed diagnosis, misdiagnosis in all areas of medicine. Now, I'm sorry, I might sound very protective of my colleagues, but let's be candid. When people say you found a number of Ugandans going to London, going to Aga Khan, going to India, how many compared to those that have stayed behind and got, I know what I'm talking about because I know the numbers. How many of them have stayed behind and got treatment that is accurate? We all know that most patients, whether Ugandans or Asians or Indians or Americans, they tend to present late for most conditions. That's number one. Number two, there is always a problem with people shopping around, moving from one doctor to another doctor to another doctor to another doctor. If I tell you, you have got a problem with your heart valves, you may say, no, 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 I must go and see Brian because Brian cured somebody who had a heart condition. That happens, and we know it, and we accept. That's why as doctors, if you want to get a second opinion, I write exactly what I have seen, what I have done, and you go to another medical doctor for a second opinion. That is allowed, that's professionally acceptable and recommended. But I must also quickly add that doctors are not gods. They are doctors, and God heals. We treat, God heals. There are conditions where we advise patients, where doctors have advised patients and say, look, this is stage 4 cancer. You will not get very much. And somebody refuses and goes to another hospital. Some of these hospitals make money. They say, oh, no, no, no. This is not stage 4, this is stage 3. The difference between stage 4 and stage 3 is academic. And they go ahead and treat them. Sometimes they improve, sometimes they don't improve. What am I talking about? I'm telling you that from what we have, from the training that we get, from the training that we do, from the continuing medical education that I talked about below, to the examination levels, you must have heard that there has been a big war about entry standards into the university medical schools these days, and it is going to stick on. We try as much as possible, but hey, people are people, and they will always have a different view. Without a doubt, doctors, as I said, are not gods. They can make mistakes. You can make a misdiagnosis, partly because you may not know, because nobody's infallible. Number 2, you may not have the necessary equipment, which is not very common. There is no doctor here who can't make a diagnosis of a heart condition using a stethoscope, not the ones that were in the medical school with me. It is very rare that you miss a diagnosis of cancer. You may not have the capacity to treat it. You may not have the capacity to exactly know how big it is. I've talked about PET. It is only 2 years ago that Nairobi got PET in Aga Khan. PET is a newer technology for making the diagnosis on cancer. Right now, they have only 3 in Kenya. South Africa got it about 2 years ago. So the new technology, we don't have PET in Uganda yet, but it's a question of time we shall get it. However, the doctors in Uganda do what is conceivably possible, but a few patients will always seek outside intervention. And they will always seek outside intervention with our clear recommendation. You want to get a second opinion, please go to Turkey. Please go to India. I have seen patients from the UK going to India. I've seen patients from America going to India, going to Thailand. And some of them actually have been to Nairobi. I even met some of them in Tanzania for orthodontic treatment because it's less expensive. So you'll never stop patients from seeking a second opinion, but it's not because Ugandans can't do the right thing. It's not that Ugandans are not as proficient doctors as anywhere else. In fact, we compete favorably, believe you me. We may not have the recent technology, and that's why we allow our patients to move on. But where we have recent technology, and the Ministry of Health is trying to do its best, we do offer that treatment. I'm sorry, I sounded like protecting my colleagues, but that is the truth. That is where the diaspora can help. Transfer of technology, transfer of information, training of students, training of doctors for newer technology. Take them to the University of Toronto and teach them. Take them to Alberta General Hospital. Take them to UK, Hammersmith, for new technology, so that they transfer that technology to be able to come back and apply it onto Ugandans.
Thank you, Dr. Warren. I saw Brian was switching. Thank you, Dr. And I think we're quite keen on ensuring these examples. For me, from the UK, I'll be in Uganda next week. And I think one of the things, I'm coming with colleagues from the UK National Health Service, and we want to learn from Uganda. You know, what we call turning the world upside down. There's a lot UK can learn from Uganda, and your colleagues are actually also perfect. So what you have said, yes, is true. We are struggling with some challenges here, access to healthcare, ethnic minorities, access late. We have the same challenges you're facing. So there's a lot of lessons we could learn. And diasporas also can play a role in how we support our communities here in where we are in diaspora, and also learn from colleagues from Uganda. I want to bring this to the end if it's we're 2 hours, but also as chair, I'm thinking of best way. Maybe the State House team can share their contacts in there so that people can follow up with other questions. If possible, allow me to bring this to the close, and I want to thank the State House Diaspora Unit, our lovely speakers who have enhanced our thinking around as diaspora where you can contribute. Mr. Boganza, thank you so much for giving us the opportunity. I think the other side we want is as diaspora, we need another conversation where we come in as well and want our colleagues to listen to us. There's a lot of questions here. I think it would be nice to give us another opportunity. Mr. Boganza, are you okay to come in and share your vision? Are you there, Mr. Bagonza?
Moses, I think.
Okay.
Hello?
Yes, go on. Sorry.
Yes, just from State House Diaspora Unit.
Yes.
Maybe I can give some closing remarks. Moses, thank you very much for this session. We appreciate your time. I understand in London you guys are paid per hour. These are 2 hours that you've given to our Ugandans. Thank you very much. I also want to take this opportunity to thank our 2 panelists. Dr. Warren Namara, thank you very much for your time. Mr. Swata Brian, we are very grateful. I was worried you leave us, but I'm grateful that you gave us all the time. From the office, I need to inform everybody that all these sessions are recorded and uploaded on our YouTube channel, State House Diaspora. You can refer to that in case you miss out of any of our sessions for this webinar series. Also, we are going to have another one on 5th of August, and it's going to be on labor externalization. So we look forward to seeing all of you here because most of you are there, and we look at what it takes, and we shall have our partners from Ministry of Labor and Gender. So from the office here, we thank everybody for coming in and participating, and wish you all the best.
I want to give you my email.
Please.
My email are my 2 names, Warren Namara @gmail.com.
Pleasure.
Warren is WARREN. Namara is NAAMARA. You can reach me, send me a message, send me a question, and I'll answer it to the best of my ability.
And Brian has posted his as well there. Very, very important. Thank you, Doctor. And thank you, everyone, for being here. Thank you.
God
Bye
bless.
for now.
Thank you, Moses, and thank you, everyone.